so that we're able to offer the best possible treatment. Some of them could be even life-saving. So we'll see the entire spectrum. We'll begin with Dr. Mahesh, and we'll go as the speakers come in and the audience as well. Thank you.
Thank you, Chaitra. So we will start. My talk is on retinal findings in lifestyle diseases. Till now, I know only a couple of diseases that are considered as lifestyle diseases, like diabetes and hypertension. So I was just going through that. There are a lot of ocular diseases due to lifestyle, ocular changes due to lifestyle diseases, but my talk is specifically on retinal findings. So I will go through some of the diseases. The retina is supposed to be the window to systemic diseases. You can see the retina and diagnose a lot of things. Can be congenital or acquired anomalies. Like this is a normal fundus. All of us know what is a normal fundus, and there are a lot of findings like Weibern-Mason syndrome or coloboma of the optic disc with midline anomalies, hemangioma with Sturge-Weber syndrome, then von Hippel-Lindau with so a lot of things are there which will be covered in the future talks. And there are a lot of acquired conditions like hematological conditions that will be covered, vascular conditions, inflammatory conditions, and even malignancies, neoplastic like metastasis. And these are some of the vascular occlusions, cytomegalovirus infections, then hematological conditions like leukemia. So a lot of acquired conditions. My talk is on lifestyle diseases, and I have to cover a few diseases which are called lifestyle diseases, and there are diseases like AMD and other RVO, etc., where it is related to poor lifestyle choices. You cannot call it lifestyle diseases. Lifestyle choices like poor diet and smoking, what I am going to cover is few things like hypertension, hyperlipidemia, and diabetes, where I will show some pictures. So, Dr. Gopal is here. Thank you. Thank you for giving us the opportunity. So, I will go through some of the hypertensive manifestations. There are two types of manifestations in the retina due to vascular retinopathies. One is hypertensive retinopathy, otherwise arteriosclerotic retinopathy. If there is no arteriosclerosis and suddenly the blood pressure shoots up, you can get hypertensive retinopathy. That is mainly in young people. And in elderly with involutional sclerosis, you can have arteriosclerotic retinopathy, over which hypertensive changes are superadded. The important thing is malignant hypertension, where we have diagnosed a lot of cases of malignant hypertension just by looking at the fundus and then checking your blood pressure. We have saved a lot of people like that. All of you might have seen cases like that. I am not going into the classification of hypertensive retinopathy and arteriosclerotic retinopathy, but you can get ischemic optic neuropathy due to nocturnal hypotension. Then there can be arthritic type of ischemic optic neuropathy, which are also systemic manifestations. That is not lifestyle diseases. And malignant hypertension, you can diagnose the disease and be life-saving. Like this disc edema, multiple cottonwool spots, and some of these cases have macular star. This is another case, acute disc edema resulting in peripapillary hemorrhages, and sometimes you can get choroidal infarct. This is not usually seen in pure hypertension. This was a case of eclampsia, accelerated hypertension in a pregnant lady, leading to choroidal infarct and even vascular occlusions. So these are cases where you can diagnose hypertension based on the retinal findings. You can have a patient with tributary vein occlusion or even retinal artery macroaneurysms, and this is another retinal artery macroaneurysms seen in cases with hypertension. So these are some of the manifestations due to hypertension in the retina. Sometimes you can get retinal artery occlusions in hypertensive patients where there is a dislocated plaque leading to arterial occlusion. You can get this retinal artery occlusion with cilio-retinal artery sparing and branch retinal artery occlusions, especially if the emboli consisting of platelet or cholesterol emboli. So this drug abuse is another cause where you can get CRAO. Now coming to the second disease, that is lifestyle diseases, hyperlipidemia. This is a classic hyperlipidemia, purple fundus it is called, and I will show one case that is enough. This patient came in 2024 with, the picture is like this, plenty of hard exudates, lipids across in the posterior pole, especially the nasal side also you can get, not like a typical diabetic retinopathy, and hyperreflective dots in the retina, even at the fovea, and angiogram shows NPDR changes with diffuse capillary leakage, and patient had a, this is angiogram, no new vessels, so NPDR with, so patient had hypertriglyceridemia with hyperlipidemia. The triglycerides was more than 600 with total cholesterol also very high, and just without doing any injection or laser or anything like that, we just started sent to and we just started anti-lipid this thing, and gradually you can see the exudates all cleared. A patient was given fenofibrate or rosuvastatin combination, and over 1 year it has become like this, absolutely gone. So this is the importance of checking hyperlipidemia in a case of diabetic retinopathy. And now the biggest menace is diabetic retinopathy. It is the most important lifestyle disease affecting the retina, and all of us, mostly half of the patients that we see in an OPD is diabetic retinopathy. The findings, you can get a maculopathy or a PDR, and the course and prognosis is different. One is blinding, one other is visually causing severe morbidity, and sometimes the DME can be having good outcome, but not always. There are recalcitrant cases depending on the systemic metabolic control. There are diabetic retinopathy with systemic implications, like these cases I told. The hard exudates are lipids are much more due to hyperlipidemia, and the other one has uncontrolled hypertension due to and plenty of cotton wool spots. So systemic implications are there in the finding, and sometimes it is vision is 6/6, very advanced diabetic retinopathy, and they all wake up after bleeding. And you can get good vision with a lot of fibrous tissue. If you touch the eye, it is likely to worsen over time. So this is tractional detachment and combined retinal detachment. And there is a small entity called diabetic papillopathy, which is ischemic optic neuropathy in diabetic, uncontrolled diabetes. So these are, and smoking can also result in AMD, different types of AMD, and rarely smoking can lead to lung cancer and findings in the retina as metastasis. So these are all some rare causes, but related to lifestyle. So a simple fundus examination can give invaluable information about the underlying systemic disease, and some cases we can prevent systemic complications and improvement in the quality of life, especially cases like malignant hypertension. Thank you.
Thank you very much, Dr. Mahesh. Thank you, Chaitra, for introducing the topic to us, and Mahesh for starting up with lifestyle diseases, which is very commonly coming up in India. So more than 60 to 70% people have either diabetes or hypertension or hypercholesterolemia, dyslipidemia, etc. And since these common lifestyle diseases are picking up, and eye is a morphological way of picking these up, we will go a long way in picking up eye signs to look at the severity of these diseases. The challenges would be, one, to pick up these diseases before visible morphological changes like hard exudates or soft exudates or such changes come up. And so that is what a lot of people are working on. And then that AI has revolutionized it, and using these images, can we pick up any of those diseases on a screening basis or for triaging them? So are there any questions here? We can go 1 or 2 questions and then move to the next talk. Are there any questions from the audience? Mahesh, you can join me here, please. Any questions? Okay, Mahesh, let me ask you. So before visible changes develop, can you think about certain paradigms where you can think about predicting these diseases, like vascular changes or vascular surface area? Has there been any work on that, the branching patterns?
Yeah, actually OCTA has detected choroidal vascularity index and all other findings which can predict systemic morbidity like hypertension and even lifespan of the. A lot of AI-based technologies are coming, but we don't do that in a clinical setting. That is the only thing. I have.
Okay, thank you very much. Next, I will invite Dr. Reema to talk on retinal features of systemic autoimmune diseases. Dr. Reema is a professor at PGI Chandigarh. She is a professor of retina and uveitis. Over to you, Reema.
Very good morning to all of you, and thank you, Dr. Gopal, for inviting me to talk in this instruction course. My topic is retinal features in systemic autoimmune diseases. So coming to the systemic autoimmune diseases, as per the NIH, there are between 80 to 150 autoimmune diseases. So what basically happens in them is there is dysregulation of the immune system, leading to activation of immune cells which attack autoantigens. There is circulation of the autoantibodies in blood which get deposited in the vessels or the organs, leading to inflammation, causing thickening of the blood vessels and leading to ultimately occlusion of the arteries. So various other factors also have an additional influence like genetic, infection, endocrine and environmental exposure. Most of the body parts can be affected by the autoimmune diseases, and broadly the autoimmune diseases are classified as systemic autoimmune diseases or organ-specific autoimmune diseases. In systemic autoimmune diseases, the autoantigens are present all over the body and the autoimmune reaction is mediated by autoantibodies. In organ-specific autoimmune diseases, the autoantigens are the organ or the tissues or specific cells, and the autoimmune reaction is mediated by T cells as well as the autoantibodies. So I'll be focusing on some of the systemic autoimmune diseases like rheumatoid arthritis, SLE, and so on. So coming to rheumatoid arthritis, we know mainly the involvement is in the form of anterior uveitis or ocular surface diseases, but retinal involvement is quite uncommon, and whatever happens usually occurs in the form of retinal vasculitis. Again, it may be asymptomatic, and that's why this article I find it very relevant, which says that retinal vasculitis in rheumatic diseases is like an unseen burden, because there is more of retinal vasculopathy, there is leak which is detected on fluorescein and patients really may not be symptomatic. There is another report of geographic choroiditis along with retinal vasculitis in rheumatoid arthritis, and there is a comparison of the choroidal thickness in these patients as compared to the healthy controls, where they found thinner choroid because of immune-mediated damage of the choroidal vasculature. Again, there are some anecdotal reports of optic neuritis with or without pachymeningitis in rheumatoid arthritis. The comparison of the choroidal and the retinal layers has been done in rheumatoid arthritis versus the healthy controls. And what has been found is that there is thinning of RNFL and the ganglion cell in rheumatoid arthritis, which suggests there is damage of axons, and the mechanism postulated is the autoantibodies bind to the RGCs, cause autoantibody mediated tissue injury, leading to apoptosis related thinning in genetically prone patients. This can impair visual acuity even in the absence of ocular symptoms. Coming to SLE, the prevalence of SLE retinopathy has been found to be 15.8% among newly diagnosed SLE patients. So it's not rare, but it's not very common also. Cotton wool spots are the most vital clue to the presence of an active SLE, and they are seen nearly in 50% of the patients who have ocular involvement. They may or may not be accompanied by retinal hemorrhages and vascular occlusions, and retinal vasculopathy, when present, is significantly associated with neuropsychiatric SLE. The term lupus retinopathy refers to any clinical manifestation of SLE in the visual system. It could be because of the disease itself, or it could be secondary to the renal involvement in SLE, or due to the drug toxicity. Lupus retinopathy has a wide spectrum. It may be in the form of lupus microangiopathy, vascular occlusion, vasculitis, hypertensive retinopathy associated with lupus nephritis, and autoimmune retinopathy. This could be as mild as this. This is one of our patients, known case of SLE but no symptoms, just came for routine screening and we found these cotton wool spots. It could be as bad as this, where the patient is symptomatic and you have numerous cotton wool spots which presents like Purshas-like retinopathy, and when you do a fluorescein it shows marked retinal ischemia in the area of cotton wool spots. So this causes profound vision loss, and Purshas-like retinopathy or PLR in SLE has a lot of significance. There is a study from China where they've screened more than 5,600 patients of SLE just over a period of a decade, of which 8 had PLR. Out of these 8 patients of PLR, 6 had CNS lupus, and this was found to be the higher in patients who had PLR as compared to those who did not have PLR. Now, surprisingly, all these 8 PLR patients had a very high SLE disease activity index, which is 20 or more, and almost always associated with a poor visual acuity recovery. I'll quickly take you through some of our cases of SLE. We saw this woman, 30-year-old woman, in June 2024. She came with right eye sudden loss of vision, no systemic diagnosis. She had no light perception in the right eye, and you can see almost like a Purshas-like retinopathy in the right eye, multiple cotton wool spots. The left eye was 6/9. When we did the fluorescein, it showed marked ischemia. There was macular edema on the OCT along with swelling of the retinal layers. So she was, because there was marked ischemia, we advised a prophylactic pan-retinal photocoagulation, started oral steroids high dose, and also got a rheumatology consult along with the relevant lab tests. Now, in 2 weeks, when her PRP was over in the right eye, she came with left eye, no light perception. Now, you can see the fundus was normal. A quick thought we had, is she malingering? No. We did a fluorescein. You can see delayed arterial filling, specifically in the inferior half. So something was there which we could not see in the fundus, and the late angiogram was perfectly normal. We took a neurology consult because she did give history of headaches and vomitings. So they advised us to, now this time we gave IV methylpred because this time the second eye got involved within a period of 2 weeks. They ordered CE MRI, MR angiogram. They did the CSF analysis. It was found to have a high opening pressure, not really very high, but crossing the borderline. The upper limit is 20. This was 22. So they prescribed acetazolamide and did a therapeutic lumbar puncture on the 4th day. These were simultaneously the investigations that we had got the reports. ESR was high, CRP was high. ANA was 1:160, but the rheumatologists were watching her because the other tests, none of the other tests were positive. Now, 1 week after the therapeutic lumbar puncture, her vision improved in the right eye from no light perception to counting finger close to face, and left eye from no light perception to 6/9. Now, again, this was not malingering because we had the visual fields. The one on the left is when she had no light perception, and within 2 weeks, you can see the reversal of the visual field deficit at 1 week. So we made a diagnosis of bilateral sequential occlusive retinal vasculitis in a case of idiopathic intracranial hypertension. The neurologist called it as IIH, a case without papilledema, and there are reports in literature of IIH without papilledema. But 6 months later, she comes back. Now she comes with these lesions, which we were looking for. Our presumptive diagnosis was SLE, but none of the investigation supported this. So she had this malar rash, lesions on the back, and this time the rheumatologist made a quick diagnosis of SLE. So basically, this was a lupus retinopathy, neuropsychiatric SLE. She was also on antidepressants, and she had a psychiatric consultation done. Optic nerve also has been reported to be involved in SLE. Again, not very common, but there are reports of optic neuritis or AION in SLE. Lupus retinopathy could also be caused secondary to the drugs, which I mean immunosuppressive therapy, because these patients are immunocompromised. So this was again a woman who was a known case of SLE, presented with sudden loss of vision in right eye. I just wanted to show you this retinitis lesion in the fovea, which was captured very well on the OCT. as a rain cloud sign. So she was having basically a fungal retinitis because of the immunocompromised state. So this was at the baseline, and this was at 6 weeks when she was treated with antifungals. Autoimmune retinopathy in SLE has also been reported, and it mimics retinitis pigmentosa-like clinical picture even on the ERG. So one has to be very careful in making these diagnoses of AIR in SLE. Systemic sclerosis, again, the disease is not very common. It's very rare. There is excessive production and accumulation of collagen leading to hardening and tightening of skin. Few reports of peripheral arterial occlusion, retinal and choroidal changes occurring because of systemic hypertension. So this is our own experience where we did ocular screening of these patients of systemic sclerosis who were enrolled for all the findings. I'll not mention about the anterior segment findings, but in the fundus we found there was an increased choroidal thickness in almost 30% of the eyes, and only one case had angioid streaks, which has never been reported. This was not a patient of myopia, so probably related to systemic sclerosis. Psoriasis has been linked with VKH. There are few reports of VKH and psoriasis, and their coexistence has been linked to because certain common HLA haplotypes. So again, we had this patient who was a known case of psoriasis, presented with initially right eye optic disc edema as the first manifestation on VKH, and you can see now he developed these bullous retinal detachments in the right eye. OCT shows it very clearly, followed by combined FFA and ICG. You can see the granulomas and the pockets of fluid on fluorescein. Even the left eye, which was asymptomatic, showed subtle granulomas on ICG. And these are some of the systemic associations of VKH where psoriasis is in the list. Celiac disease, again there is an immune reaction to gluten, and there are case reports of CRVO and combined CRO and CRVO in celiac disease. Similarly, in Crohn's disease, retinal vasculitis, and simultaneous arterial and venous obstruction of the retinal vasculature. So to summarize, retinal involvement is rare in systemic autoimmune diseases. It can be asymptomatic, but it can be sight-threatening, and we have to be very careful in making diagnosis and picking up these arterial occlusions. Thank you very much, and thank you, Dr. Gopal, for this opportunity.
Thank you very much, Rima. So there are a lot of systemic vasculitis and autoimmune diseases which have their signature marks in the retina. I would just like to ask you one thing. When we classify vasculitis, we classify into large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis, apart from the idiopathic or other retinal vasculitis that we know. So would you please shed some light on how to differentiate between the large vessel vasculitis, which is exemplified by the carotid arteritis, versus a medium vessel vasculitis versus small vessel vasculitis based on retinal examination?
Okay, so I think in this context, Takayasu retinopathy would be most appropriate, and I think it will be covered by, I didn't cover it because I thought it would be covered by under cardiac and neurological. So anyway, Takayasu retinopathy may be detected, one, in a known case of Takayasu. Sometimes they're not known cases, and the ophthalmologists make a diagnosis of Takayasu. So here you have it's a granulomatous autoimmune inflammation of the large, primarily the aorta, involving the common carotid and then involving the ophthalmic artery. So here you have these hemorrhages, tiny hemorrhages or maybe microaneurysms in the periphery, coupled with findings of low IOP, feeble pulse, or sometimes that's why it's known as a pulseless disease. And clinically, you just see these subtle hemorrhages all over the fundus, and you do an angiogram and you find all the stages of Takayasu retinopathy.
Okay.
So I'm sure it will be covered in
Thank you very much. So let's move on to the next talk. Dr. Neha Goyal, can you please speak on the retinal findings in cardiac and neurological diseases? Please come. Yeah, we'll have some discussion at the end of the session now.
Good morning, everyone. I welcome you all to Delhi. And first of all, I'd like to thank Dr. Gopal for including me in this instruction course, which I think is very, very relevant and very important to us. I'll be talking about retinal findings in cardiac and neurological diseases. So we hear this often, the eyes are a window to our soul, but they are also very organically a window to the circulatory system. And probably retinal imaging is the quickest and easiest and most non-invasive way of directly looking at the blood vessels anywhere in the body. Apart from that, the microvasculature of the eye is also unique in that it has a high circulatory resistance, and hence it becomes highly susceptible to any alteration in the systemic circulation due to cardiovascular diseases. The retina requires more oxygen per gram of tissue, even more than the brain. So under any stress or pathological condition, the changes in the eye microvasculature may actually precede the systemic changes or occur concomitantly. And again, as I said, these can be easily visualized during a fundus examination. So let's talk about some of the disorders which we encounter. Acute vascular diseases, arterial dissection, not very common but life-threatening, and though they usually present to the cardiologist, but they may on retrospective history taking reveal episodes of amaurosis fugax. A painful Horner's is something which should alert you, and of course ischemic optic neuropathy, ocular ischemic syndrome, or even CRAO may occur concomitantly or may precede the episode. More commonly we see patients with infective endocarditis where we are sent referrals, and rod spots are the classical manifestations. You can see these white-centered hemorrhages which are actually aggregates of the platelets, fibrin, and the emboli. Apart from the rod spots, you can have septic emboli in smaller vessels leading to cotton wool spots or BRAO, in the larger vessels leading to CRO, and sometimes even ophthalmic artery occlusion. These may even present with white patches such as focal retinitis or the embolic retinopathy or subretinal abscess, and even CNV has been reported secondary to these emboli. Endogenous endophthalmitis might happen in infective endocarditis. It is commonest with Staph aureus and more common in the right eye because of the straight path from the heart, and rarely you may get papillitis or optic neuritis. Takayasu arthritis was just being talked about, and there are three distinct patterns which you can get: the classic hypoperfusive retinopathy or the Takayasu retinopathy, or since these patients have associated hypertension, you can get hypertensive retinopathy or a mixed retinopathy as well. They may also have episodes of amaurosis fugax, and remember, because the artery and the vein have a common adventitial sheath, they can also present with BRVO, even though it is a arthritis pathologically speaking. Now, giant cell arthritis, as Professor Harre has ingrained, that any patient over the age of 55 who presents with amaurosis fugax, diplopia, or visual loss with AION, CRAO, celoretinal occlusion must be suspected of having GCA unless proven otherwise. A simple ESR or CRP can alert you, and it may be instrumental in saving the other eye from permanent visual damage. Now, coming to subacute or chronic vascular diseases, the cerebral, cardiac, as well as the retinal arterioles are similar in terms of anatomy and physiology. If you look at the literature, then you realize that the risk of stroke is actually 2 to 3 folds higher in people with hypertensive retinopathy, independent of cardiovascular risk factors. Hence, we must encourage our physician colleagues to send more and more referrals for evaluation of hypertensive retinopathy. So starting with the carotid artery disease, this is the commonest we see, where the ocular findings actually alert us to the presence of a systemic disease. And in acute cases, apart from amaurosis fugax, you can get these Hollenhorst plaques, which may sometimes even be asymptomatic, or as here you can see these plaques, or they can cause a arterial occlusion, either a branch or a central. In chronic cases, we get what is known as venous stasis retinopathy, and this can easily be confused with central retinal vein occlusion. But I'll show you some cases here. The typical picture is the sludging of the blood in the veins. The veins become darkened, as it is classically said. The hemorrhages are not as much as CRVO, and the angiography clinches the diagnosis. So venous stasis retinopathy may in fact be an earlier stage of the full-blown ocular ischemic syndrome. So this was a 55-year-old male. The right eye was asymptomatic, though you can see some venous dilatation here in the inferior. part, and this is the left eye. So if you look at the veins, you can see the darkened color and the thickening of the veins. Very subtle hemorrhages. These are deep retinal hemorrhages. And on FFA, you say delayed filling. Along with this, typical small vessel telangiectasia and ischemia that you see in the periphery. Also mid-peripheral microaneurysms, especially if the patient is not a diabetic, these should alert you to the presence of venous stasis retinopathy or even early ocular ischemic syndrome. So this patient was then sent for cardiac evaluation, and in the left eye there was 100% occlusion or stenosis in the ICA. The right eye had about 70%. So at this stage, the intervention cardiologist can prevent the sequelae such as stroke. Now, another lady, right eye, had media haze because she was 65 because of cataract, and this was the left eye. Again, you can see the darkened veins, very subtle hemorrhages. And on FFA here, you can see asymmetric filling. And again, the small vessel telangiectasia and ischemia along with microaneurysms in the mid-periphery. Now, she again had complete ICA blockage on that side, which was the left side. Unfortunately, despite PRP, she went on to develop neovascular glaucoma and had lost vision in this eye, secondary to the glaucoma. So next, coming to systemic hypertension, the retinal vasculature is actually protected from fluctuations in systemic arterial pressure because of the autoregulatory mechanisms, but naturally they fail beyond a particular blood pressure. So in acute hypertension, the choroidal vasculature may be affected more because of this reason. The retinal vessels, they maintain their vascular tone longer than the choroidal vessels. But in cases of chronic hypertension, the changes are more in the retina. So here we know the classic hypertensive retinopathy and the stages, but I'd like to say here there's a wide intra and inter-observer variation, especially, you know, like in certain institutions where you have to grade the patients or classify them into categories, being in the armed forces or because of their employment. So it's a good idea to take photographs and then document the stage they are in. So these are some of the patients we see. Grade 3 hypertensive retinopathy without involvement of the optic nerve. You can see complete and incomplete macular stars here, a preponderance of cotton wool spots. Now, coming to some of the less commonly encountered cardiovascular conditions. So congenital heart disease, the children have said to have more vascular dilatation and tortuosity in the cyanotic type of congenital heart disease, mainly because of polycythemia and hypoxia. And this has been seen to reverse to an extent after surgical repair. Now, this was a child we had seen long back who presented with proliferative retinopathy, and he was a known case of teratology of Fallot, and we hypothesized that the chronic ischemia had led to this kind of proliferative retinopathy. So apart from that, cardiac myxomas again are rare, but we must be aware of the Carney complex where they may have ocular myxomas as well. And cases of pulmonary hypertension may again present with venous stasis retinopathy. So a word about the future. As we just discussed, the retinal changes may occur concomitantly or precede the cardiovascular catastrophes, and we may actually, allow interventions which may be life-saving for the patient. So just looking beyond the fundus and a high clinical suspicion can save many of these patients. A word about the integration of AI in retinal imaging. So along with a lot of cardiac imaging and cardiac biomarkers, there is now a system to risk stratify those patients who are at risk of developing either heart failure or stroke, and retinal imaging is a part of that scoring system. In fact, in many of the service hospitals, I'm aware that they have the cardiology department, without our intervention, have the non-mediatic smartphone held fundus cameras, and they are using this to stratify their patients as well. Now, coming to the second part of my talk, the retina is also an extension of the brain, as we know, and retinal manifestations of structural and functional deterioration are interlinked with the development of neurodegenerative disorders. In fact, extensive work has been done on this, and I feel that we use our OCT, we underutilize our OCT in the field of neurodegenerative disorders. Now, the retinal changes may occur, I'll just take 2 minutes more, as a primary pathology or secondary to the transsynaptic changes. As we know, the entire pathway involves the retina as well. Now, these surrogate markers are very exciting because, first of all, they can predict the onset of disease. They can be used repeatedly to follow up the patients non-invasively. There is no ionizing radiation, unlike a CT scan or an MRI, and no use of contrast agents as well. So Alzheimer's is the one on which the maximum work has been done, and the peripapillary RNFL loss is said to be the most sensitive indicator. This is a global loss as compared to Parkinson's disease, where it is more of a temporal loss. So OCTA has also been used to quantify the retinal vascular network in the deep and superficial plexus, and it has been seen that the FAZ is enlarged. Interestingly, this correlates with the mini mental state examination, the MMSE. So really we need to work in conjunction with our neurology departments even more. Multiple sclerosis, as we all know, the association of optic neuritis, but I'd just like to highlight the microcystic macular edema. This was one of our cases. So here you have cysts in the ONL, which can be confused with edema, but they do not leak on FFA, and there is this typical appearance on OCTA, which can be quite dramatic as well. Susak syndrome is another neurological disease which can present with multiple BRVOs, and we may be the first to diagnose it. Last word about the neurocutaneous disorders. So we know of neurofibromatosis type 1, where usually they present with optic nerve gliomas, but we've reported a case of peripheral retinal ischemia. Tuberous sclerosis can present with astrocytic hematomas, either diagnosed cases or we may be the first to pick this up. This was a large symptomatic astrocytic hematoma with exudative RD, which led to loss of this eye in a young child. And then the very obvious Sturge-Weber syndrome. Here they can have ipsilateral leptomeningeal hemangiomas along with the choroidal hemangioma. So these are not cases of VHL, but this is what a retinal capillary hemangioma looks like. So finally, this case presented with bilateral macular retinitis, and honestly we didn't know what it was, so we sent it to Retina under their diagnostic and therapeutic challenges, and there was acute macular retinitis. Within a period of days it progressed to complete loss of the retinal layers, leaving only the ILM intact. And along with the expert opinion, the patient turned out to be a case of SSPE. Unfortunately, he was a young boy and lost his life within the first year, but the retinal changes manifested first, and this was one of the earliest reports of that condition. So to take away, the retina is actually the only portion of the CNS which is optically accessible for high resolution imaging without the use of radiation at a relatively low cost and without the use of any contrast. So the association with neurodegenerative disease severity have been demonstrated, and these actually provide a lot of possibilities for disease assessment and even therapeutic interventions in the future. Thank you for your patient hearing.
Thank you very much, Neha. Please join us here. For want of time, let us move on to the next talk by Dr. Alok Sen. No, Chaitra. Okay. Chaitra will, Dr. Chaitra Jayadev will speak to us on retina in hematological diseases.
Thank you, Gopal, for this IC. I think it's very important because as we've covered so many interesting talks already, I will start off with Neha's last statement where she said the retina is the extension of the CNS. As you can see, it's also the only organ where the blood vessels are visible directly. So any condition that can affect the hematological system is also first visible or easily visible without the use of any blood draw or any radiological imaging. That becomes us as the first point of contact for several patients with disorders affecting the blood. Okay, so let me start with this case. This is just seen last week. This is a patient who presented to us with a gradual blurring of vision. Most of the other common systemic parameters that we look for, the blood sugar, hypertension, cholesterol, was fairly all within normal limits. If you can see, he's just been a hypertensive for 10 years, not longer than that, and everything under control. He had undergone cataract surgery. So when I checked his retina, the right looks absolutely normal, but if you see, the left has multiple intraretinal and preretinal hemorrhages along the superior temporal arcade, along with a hemorrhage of the fovea. Some have felt, given that the systemic parameters were quite under control, why did this patient develop this unusual presentation? Which prompted me to send him for some blood investigations, and what turned out was myelodysplastic syndrome. So you see, if we had not really thought a little further into this particular patient, we probably wouldn't have detected a life-threatening condition, which is why retinal manifestations in hematological disorder is an extremely important topic, and let's look more into it. Most of the typical findings have already been described by the previous speakers, but what we normally see is retinal neovascularization. We can see rod spots, which Dr. Neha showed, hemorrhages, a lot of them, different presentation than what we typically see in systemic disorders, serous retinal detachment. We can see hard exudates, cotton wool spots, and also disc edema. So these are some of the findings. Now let's go straight into some of the common conditions that we need to be aware of. Well, beta thalassemia is an autosomal recessive. It causes basically hypochromic microcytic anemia. It's a quantitative defect of the hemoglobin synthesis. So retinal manifestation could be because the disease itself or due to the therapy. Now when you look at the findings here, you can have either PXC like, that is pseudoxanthoma elasticum like features, or non-PXC. So you see pudgy orange. You also see angioid streaks in these patients and retinal hemorrhages. Other manifestations are edema, papillitis, and macular scarring as well. Now sickle cell this is basically a result of vascular occlusion, capillary non-perfusion, neovascularization, and then the subsequent complications. I am not going to the detail of the disease, but like I said, the two major complications are either due to hemolysis or vaso-occlusive crisis. So this is the Goldberg classification, where you see the different stages, and in stage 3 is when we start seeing neovascularization, stage 4 is vitreous hemorrhage, and finally TRD and rhegmatogenous RD as well can be seen in these patients. So retinal findings, here you see silver wiring, you also see salmon patch hemorrhages, you can see these black sunburst appearance, the iridescent spots, and then neovascularization, the typical CFAN type, and then finally when you have autoinfarction, you see silvery ghost-like vessels. Why does the CFAN neovascularization occur? It's primarily because there is non-perfusion that leads to the development of Muller cell hypoxia, and then you have VEGF, and then finally you see this perfusion, between the perfusion and the non-perfusion area, you see the CFAN, and most commonly it's seen in the superiotemporal quadrant. Now the typical salmon patch hemorrhages you see in the temporal mid-periphery here, and the angio will show leakage corresponding to the neovascularization as well. Other conditions that we see are thrombophilia, hyperviscosity syndrome. Here basically the blood viscosity is affected and it disrupts the coagulation cascade. Then there is compromised blood flow, ischemia, and the subsequent changes. The most common ophthalmic finding is retinal vein occlusion. Now also plasma dyscrasias, I will show you a couple of cases. This is due to paraproteinemia, and one is Waldenstrom macroglobulinemia, and you also have erythrocyte aggregation here causes venous stasis, retinopathy. You can have vein occlusion and then hemorrhages, exudates, and serous macular detachment. So some of the other retinal findings that you see here, this is a patient with Waldenstrom's, is multiple flame-shaped hemorrhages. This is a patient with multiple myeloma, serous retinal detachment, and deposits as well that you can see. CRV was very common, and you also see venous bleeding in these patients. And some of the other conditions that are associated with hyperviscosity syndrome is polycythemia, multiple myeloma, leukemia, hyperlipidemia, and severe dehydration as well. So you also have hypocoagulable states here, and some of the conditions are anticardiolipid antibody syndrome, and also you can see in these patients presenting with BRAO. Ophthalmic artery occlusion and choroidal infarcts, I think we've already seen in a couple of cases that were present previously. This is a patient with immune-mediated thrombocytopenia, and this was a presentation in one of our patients where you see predominantly peripapillary. Bleeding disorders, again important, these are the different findings, quite common and overlapping, which is why our systemic investigations would be most important. DIC again can be both thrombotic and hemorrhagic phenomenon. Different findings are quite similar here. You see pseudo rod spots in these patients. Optic disc swelling can also be seen. Anemia is a talk by itself, but these are the different findings. Most importantly is there is no direct retinal treatment for these patients. Management of the systemic condition becomes very important. Leukemia is also the different retinal manifestations. And the optic nerve, very important in patients with leukemia that we need to look for. any sort of disease relapse that you can see in terms of infiltration here, as you can see in this patient with leukemia. This is another patient who presented to us with central retinal artery occlusion with cilioretinal sparing. Some of these patients may actually not even realize that the vision has come down because systemically they are so ill. So, it is very important if you are in a multi-speciality hospital to make sure that they are quite followed up well enough. Another patient here with venous stasis retinopathy first presented with central retinal vein occlusion, and then subsequently the same patient developed central retinal vein occlusion. So, you can see both of them with disc swelling and infiltration as well. So, how has management changed for us? Now, see, this is some of our cases that we have published. This is a 56-year-old Asian Indian male who was on regular follow-up for us for stable non-proliferative diabetic retinopathy, and suddenly in a few months he presented to us with worsening of the disease. He had decreased visioning, and you can see even the pathology has changed. It's quite atypical macular edema in both eyes. We were wondering why suddenly systemic parameters were quite okay. But when we worked up this patient, he had severe thrombocytopenia. And we were wondering, we sent him to a hematologist, and luckily for us, the hematologist also went on to run an infection panel. And this patient turned out to be HIV positive, and this was HIV induced thrombocytopenia. So, that was something that we learnt new, and of course, given the significant inflammation and macular edema, a cocktail of intravitreal bevacizumab, ganciclovir and dexamethasone was given, and this patient improved to 20/20. You can see an extremely good improvement over the next 6 months. So, you see how it can be such a confounding factor if you do not think that it can be beyond just the simple diseases that we see on a day-to-day basis. This is another patient who presented to me again with sudden worsening of diabetic retinopathy, we thought at that time. But you see that the edema is quite atypical. These are the angiography, we did not really find anything, and then it just kept getting worse and worse. Just look at how different the macular edema is. So, this turned out to be paraproteinemic maculopathy, and the patient had multiple myeloma. So, once he underwent treatment for multiple myeloma, of course, we could not really restore normalcy as far as the vision goes, but at least we were able to figure out a systemic condition. So, to conclude, more than 80% of our retinal diseases are secondary to systemic pathologies. Ocular findings made the first presentation to identify a life-threatening systemic condition, as I showed you in our cases. Screening of the retina also therefore becomes very important, because like you see in patients with leukemia, you can also figure out if there is any infiltration, etc. Thank you so much.
Thank you very much, Chaitra. So, may I ask you, like many of these patients will come to us with hematological diagnosis, and then you may say that, yes, let us see these are the findings. But reverse, when you see a retinal finding, which will be the cases which you would want a blood investigations, hematological, not routine blood investigations, hematological investigations in?
Yeah, so like I showed you in a couple of cases, when patients are not responding to routine treatment, or if their conditions which are prone to these findings like diabetic retinopathy, or if it's hypertension, or if the lipid profile is deranged, homocysteine is all within normal limits, and still the disease is worsening, that's when we have to raise an alarm and go for the next round of investigations, would be blood specific. Or if there is no response to treatment, like the second case that I showed you, I kept giving him intravitreal injections and the edema was worsening, which itself again is an alarm that okay, something else is going on. That particular patient, I'm so glad, because eventually he went to Tata Memorial and we were able to save his life. It was quite a significant thing, and even till today, though the patient is from somewhere in Jharkhand, he comes back because he realized that we picked something that is probably responsible for his survival today. So I think two things: one is atypical findings, second one is poor response to treatment or unusual response to treatment. I think those two are the key take home.
Thank you very much, Chaitra. You can join us. Yeah, and next let me call upon Dr. Alok. He will be talking to us on retinal findings in systemic infections. Alok is heading retina at SNC Chitrakoot.
Yeah. Good morning to you all, and thank you, Dr. Gopal, for this opportunity. So I'll be speaking on some of the retinal findings in systemic infections. The list is exhaustive, so I have restricted myself to 7 cases and since the theme of this IC was Sherlock Holmes, I thought that it would be interesting to present some of the cases. So there is no financial disclosure, although I would like to acknowledge Professor Amod Gupta, without whom I would not have been standing here today. So this is the first case, a 47-year-old male, diabetic on insulin, who presented with sudden diminution of vision in the left eye. And he had history of fever 7 days back, and which was diagnosed as typhoid. So it was a straightforward case for us. We thought that this is endogenous endophthalmitis. We went ahead and did vitreous biopsy, which turned out to be positive for Salmonella typhi. We treated and we got a good outcome, although the vision didn't improve much because of the macular involvement. But this case, again a diabetic, who presented to us with a similar kind of picture, vitritis, with a kind of chorioretinitis, which you can see, focal chorioretinitis. He had foot ulcer for which he was receiving treatment with higher antibiotics. And to add to the confusion, his VDRL and TPHA both came positive. He was HIV negative, he had anterior segment, and you can see severe vitreous involvement. So what we thought, what we are dealing with, is it endogenous endophthalmitis, is it syphilis, is it toxoplasmosis, because that can also present like this. But what gave us the clue was this OCT picture, which I think Dr. Rima had already shown in one of her case, the rain cloud sign. And this is typically seen in Candida endophthalmitis. So we did pars plana vitrectomy, and we also found yeast-like fungus, and we made the diagnosis of fungal endogenous endophthalmitis in this case. Of course, we had to treat this patient with for syphilis as well. So endogenous endophthalmitis can have various presentation. Mostly they present in patients who are immunocompromised. But in our setup, IV fluids, contaminated IV fluids are an important risk factor for this. Of course, you will have to have a very high index of suspicion to make a diagnosis. And PPV is probably both diagnostic and therapeutic in these cases. Now, this is one of our case, 31-year-old male who presented with history of fever for 5 days and presented with this kind of creamy white necrotizing retinitis without much of inflammation, neither anterior segment nor posterior segment inflammation. And the other eye also showed placoid lesions in predominantly in the posterior pulp, but also few in the periphery. Now, as we were thinking of the diagnosis about 10 years back, Professor Amod Gupta was in Chitrakoot, and we showed similar kind of case to him as a case of which we were unable to figure out, and he had shown that this case was of SSPE. So having that in mind, we decided to go in and do an OCT, and the OCT typical, which was very typical of full thickness necrotizing retinitis with sparing of the ILM ballooning, and the sparing of the choroid. And if you can see these two pictures, this was just within a day's time that the retinitis has progressed. It was a rapidly progressing retinitis. So we went ahead and did CSF analysis, and it turned out to be a measles retinopathy or SSPE. Unfortunately, again, this patient died after a few months. Now, so SSPE is the diagnosis is basically based on Daikin's criteria. Unfortunately, there is no ocular criteria for diagnosis of SSPE. Usually, the ocular involvement is seen in 50% of these cases, and some of the cases, the eye may be involved before the neurological symptoms come. And there is usually a rapidly progressive retinitis without much inflammation in the eye. And the OCT is very classic, and as shown by Dr. Neha as well. Now, this patient who came to us from Bhopal, and he was under treatment for post-fever retinitis with azithromycin and steroid. And when we examined this patient, he had this rash in the palms, as well as this ground glass retinitis with some pink punctate retinal involvement retinitis. And this gave us a clue that we might be dealing with syphilis. And we questioned him further, and he gave history of genital ulcers. And he turned out to be positive for syphilis as well as HIV. We treated the patient accordingly, and this is the response that we got. Another patient who had this placoid lesion in the posterior pole, which is very typical of syphilitic chorioretinitis. And what you can also see on the OCT is those nodular dots that you see. And if you see this, there are only few differential diagnoses, and one of this is syphilis. This patient we treated with IV ceftriaxone for 14 days, and you can see the outcome. So ocular syphilis can have a merit of manifestations. However, if you see these two type of presentation, you are by and large sure that you are dealing with syphilitic uveitis. Now, this patient who was a 70-year-old and presented with us with a neck swelling, a mild pain in the eye, and you can see some congestion. And on examination, what we also found, which you can see on the picture, was a mass in the ciliary body region, which can also be seen on the UBM. And there was evidence of peripheral vasculitis. Now, this patient, we did a routine investigation for uveitis. The MAN2 was negative, but when we did HRCT, what we found was a presence of miliary tuberculosis, and when we did FNAC from the thyroid mass, we could demonstrate acid fast bacilli. We treated this patient on ATT, and this was the response. Another case, a 37-year-old male who presented with blurring of vision in both the eyes, and you can see multiple choroidal lesions along with disc swelling, and there was infiltration of the disc as well. Now, this patient, if you see the OCT, which showed a full thickness granulomas, lobulated granulomas, and you can also see at one place there is some amount of subretinal fluid and what is known as contact sign as well, outer retinal involvement. Again, MAN2 was negative, but the HRCT showed presence of miliary tuberculosis. So we treated this patient with ATT and steroid, and this is the response. So TB uveitis, and we have an expert over here, Dr. Rima, can have varied presentation. The diagnosis is usually presumptive and used on the basis of typical phenotypic presentation and positive immunological test. In majority, we don't have any evidence of systemic tuberculosis. However, patients with miliary tuberculosis can also present with ocular involvement, and in most of these cases, the MAN2 is negative, and HRCT can be very valuable in these cases. So despite of a formidable blood retinal barrier, a variety of pathogens can invade the eye, and ocular manifestation can be the first evidence of systemic infections in these cases, and hence you need to have a very high index of suspicion, take a good history, do a very thorough clinical examination, and do targeted labs to make a diagnosis. Thank you very much.
Thank you very much, Alok. So systemic infections are often, you can please stay here. We'll just have a small discussion before we move into, change gears and move into neonates and infants. So we'll just have we have half an hour more. So we'll have a quick discussion on some of the topics that we had. So systemic infections by far is very, very important because it's always life-saving immediately. There is immediate life-saving. So tuberculosis is one common thing which is coming. So a lot of findings, tuberculosis and syphilis can mimic almost everything. So you showed that MAN2 is not a sacrosanct or anything like that. If you investigate further, you will probably come to know. So how much do you investigate? Probably Rima can also come in here. So how much would you think that there is vasculitis, there is retinitis, there are features suggestive of tuberculosis, but systemic tuberculosis is not there. How much should we investigate? And should we get a vitreous tap for PCR, how sensitive or specific is it? Or how much should we be doing?
Thank you, sir. That's a very difficult question to answer, but since the diagnosis of ocular tuberculosis is predominantly presumptive, most of these cases will not have any evidence of active systemic tuberculosis. So we rely on the typical phenotypic presentations that have been beautifully described by Professor Rima and Professor Amod way back in 2007. So if you have those typical features along with some support corroborative evidence of TB, like a positive MAN2 or a radiological evidence on HRCT of lymphadenopathy, then we tend to treat them as ocular tuberculosis. In PCR usually we don't do it routinely in most of the cases unless until it's an atypical presentation. I don't have much experience on PCR. Maybe Dr. Rima can add on it because they have done a lot of work on this. But mostly our diagnosis is presumptive based on the typical phenotypic presentation along with some corroborative evidence of TB. For patients who have systemic TB, it is much easier. Because then you have an evidence of systemic disease, as I have shown in a couple of cases. Those cases are much easier to diagnose than the ones where you don't have any evidence of TB. But certain phenotypic presentations which are very typical of TB may be very helpful in different.
Rima, you.
I think Alok covered most of the things. So if you go by the COTS publications, to add on to what we have published earlier, some of the clinical signs are very, very, typical of TB unless proven otherwise. So if you have a serpiginous like choroiditis, systemically the patient is absolutely normal. One immunological test is positive is enough. CT chest, if positive, fine, even if it is negative. If it is serpiginous like choroiditis, you have from the endemic country, go and treat with ATT. That is the COTS recommendation. For clinical phenotype of retinal vasculitis, any of the immunological test positive, along with a radiological test positive in a non-endemic country, or in an endemic, if you don't have a positive radiological test, go for diagnosis of TB vasculitis. So the main is the clinical phenotype with or without the immunological tests.
Okay. Thank you. So next I would just bring your attention to Mahesh. Mahesh, we spoke about a lot of lifestyle diseases. One of the important lifestyle diseases is obesity. Another one is, sleep apnea. So do you have some thought processes on that?
Yeah, actually, sleep apnea is something we grossly underdiagnose. Nowadays, in chronic CSCR also, we take history, and they all, many of them have sleep apnea. So sleep studies are getting more and more importance, especially if the person is having obesity also. So I think sleep studies should be considered. I think it is involved in other diseases like glaucoma also.
Yeah. Generally in sleep apnea also, what happens is because of compensation, hemoglobin increases. And many of these people will have hemoglobin more than 15, 16, and they can go into hyperviscosity syndromes, and they can move into vascular blocks as well. Yeah. Next, cardiological and neurological diseases. Based on OCT, Dr. Neha, can you say whether somebody is, at least if it is an advanced Parkinson's or Alzheimer's, can you say the differences between an Alzheimer's retina versus a Parkinson's retina? A lot of interest have been put onto that.
Yes, absolutely. And as I said, I think we underutilize it as a tool in association with our neurology colleagues. So one of the problems is the age of the patients. This is also the age when there is age-related, deterioration of the RNFL and the ganglion cell complex, the GCIPL, which is said to be quite sensitive. But like I said, in Alzheimer's, there is more of a global loss vis-a-vis even glaucoma or the age-related deterioration. And in Parkinson's, because more of the parvocellular pathway is involved, it is the papillomacular bundle which is affected, and hence more of a temporal loss. But to look at a single OCT and give the diagnosis is not advisable. It's a longitudinal change in conjunction with the rest of the systemic parameters, which is why the AI algorithms might be able to be much better than just a single scan and we give the diagnosis.
So maybe earlier tests to pick up, early parvocellular loss may go a long way in screening these patients.
Screening patients at risk, absolutely.
Yeah. Any other question anybody has in the audience? Please feel free to ask now. Yeah, please. You can go to the mic, sir.
Hello, good morning. Wonderful session. I just wanted to know that when we have made a presumptive diagnosis of a tubercular-related etiology, then what would be the duration of the treatment for the ATT, and how do you decide that what is the right time to stop?
Yeah, you can take it.
Okay. Thank you. And so we usually tend to treat these patients a little longer, about 9 months to 1 year before stopping. Most of these patients, in TB, presumptive TB uveitis, the treatment with ATT is basically to prevent recurrences rather than treating the disease. Most of the cases have to be treated with additional steroids as well. So once the disease is quiescent, you can continue with the ATT for about 9 months to 1 year. That is when we stop. But some of these patients, like serpiginous choroiditis, may require long-term immunosuppressants as well. So you may have to continue with the immunosuppressants for about 2 years before thinking of stopping it. Dr. Reema?
Yeah.
Chandran sir. Yeah.
So rightly said. For ocular tuberculosis, the minimum we give is for 9 months, but that's now becoming the maximum also. So I would say 9 months. And we really don't continue the ethambutol for the entire period because the new regime by the pulmonologist is keep giving ethambutol. But you know, we have seen a lot of patients coming back with optic nerve, damage. So we give it for 2 months, the 4 drug, and then wean them off from ethambutol, and the revised regimen is given for 7 months.
And I just wanted to put another question for the expert panel, that suppose we are given ATT and the patient was quiet and asymptomatic for a period of 2 or 3 years, and then there is a recurrence. So how would the treatment be different in the second episode from the first?
So you mean to say the patient has received ATT?
Yeah.
In the first
episode? Received
episode?
it for about 8 to 9 months.
So the second episode of
for 2
recurrence.
years he's been asymptomatic, there's no problem.
So recurrences are treated with steroids and immunosuppression. We don't repeat ATT for a recurrence.
Thank you.
Chandra sir.
Yeah, I'd like to know if the retinal, cardiac and cerebral vessels are same histologically.
Chandran sir, we are deeply honored by your presence. And a googly question, very basic in nature. Neha?
Yes, sir. That is what the literature says. They are similar, and the cerebral and cardiac vessels are more similar to the retinal vessels as opposed to the choroidal vessels. And that is why, like I said, in the acute diseases, we might see changes in the choroidal vessels because they don't have the vascular tone. But in the chronic diseases, the changes are seen more in the retinal vessels. So histologically, they might be more similar. Also, I think blood vessels everywhere are similar in terms of the 3 layers, but like we said, because the retinal vessels are so easily visible, they reflect the concomitant changes in the cardiac as well as neurological arterioles and venules. Thank you.
Thank you. Next, let us move into our next talk by Dr. Anand Vinekar. He will be talking about retina in infants and neonates.
Thank you, Gopal, and thank you for having a pediatric and infant topic in this very beautiful session. I have no financial disclosures. The most important thing about all of these cases that I'm going to present are all of these babies were detected during ROP screening. So, of course, that is a Bergsonian bias, the fact that we are going to be looking at preterm babies who may be more vulnerable to many of these conditions. How common are they? If you look at a universal publication that we saw, there can be anywhere between 4 to 11% of even systemically normal babies who have these conditions. And this was a study we did in the first 72 hours of birth of over 1,000 babies, and we even found retinoblastoma and salt and pepper retinopathy, which then led us to diagnosing other systemic conditions. However, in preterm babies, it's even higher. Anywhere between 11 and 15% of these preterm babies have several conditions that we can detect early and co-manage with neonatologists and pediatricians. I'm going to share some of them. Endogenous endophthalmitis, clearly a baby is not undergone external trauma. So if you see vitritis or you see exudative patches, it must be endogenous endophthalmitis. Easy to suspect, more difficult to treat. One has to investigate. Now this was a very curious case where we found a very small patch of retinal vasculitis. Our UVA colleagues suspected it was fungal etiology. It was worked up for fungus, and we found a perinephric abscess of candida. And this baby was actually immunocompetent, and you can see the hyphae in the urine. Because of this early detection, this baby survived. Choroidal lesions can either be neoplastic or of course they can be infective. So how to diagnose an infective condition? You will see this will be variegated, irregular surface, multi-pointed and very often affecting the macula. But when you see these more deeper white lesions, one tends to think it's a dystrophy, but it can also be a very early salt and pepper retinopathy, and we know how common that is in infective etiology. So it's important to investigate the infection before we delve into the inherited retinal dystrophy space. Hematological. I think a lot of these conditions have been spoken by previous speakers, but in an adult scenario, thrombocytopenia was spoken about. So this was a very classical case what mimicked an aggressive ROP, but actually had very severe thrombocytopenia, and just the correction of platelets resolved the disease without even any anti-VEGF. And the beauty of that is because the alpha granules inside the platelets have a normal anti-VEGF-like properties, something that we learned after we detected this case. We went back and did a retrospective series to see that thrombocytopenia is indeed a unique risk factor for aggressive ROP. This is a case of about a 2.5-year-old who then went on with longer follow-up, who had a bilateral combined central retinal artery and vein occlusion with fortunately a cilio-retinal artery sparing, went from PL vision to 6/12, all because I think we detected that early and the child was treated with low molecular weight heparin, which perhaps altered the course of the disease, and the child went back with good useful vision. And then you see these very horrendous looking capillary hemangiomas, which must alert us to the fact that this child may have neurological conditions. As far as metabolic conditions are concerned, I think these are the ones that we've been taught about from our undergraduate days, the so-called cherry red spot. And yes, they can be bilateral, but sometimes it's important to know that they can be asymmetrically unilateral, and that's when the diagnosis is missed. Autoimmune, not very common to find retinal findings, especially in infants, children less than a year. But here we actually discovered a pediatric VKH case, and we didn't think it was that until the angiography showed the very classical hypo to hyper with the disc staining, and then it was eventually treated. Unfortunately, the child died of a systemic infection before a longer follow-up was achieved. Albinism, very common in our setup perhaps. Oculocutaneous albinism, easy to diagnose. It's important here that only about 40 to 50% of them actually have the classical foveal hypoplasia. And these images are taken a little awkwardly because of the nystagmus, and the eye is not really going to stay in a single place. Down syndrome, the most common trisomy, trisomy 21, and this you can literally diagnose by looking at the nasal quadrant, what they call crowded or supernumerary vessels. You just look at those vessels, they are crowded along the nasal side, they are also more tortuous, and their foveal contour is not normal, which got us into what Dr. Neha was talking about, that the OCT really points us to neurological conditions even in children. So here was a series of where we looked at Down's children, and we found that their OCTs and their visions were actually fairly comparable to a normal OCT of that age up till the age of 2. And after the age of 2, they actually have a decline, and then they have changes in their OCT that mimic a preterm baby, which means that there is regression of milestones, and that's exactly what happens in their brains. Their neurological tangles and other changes that happen in the brain are mimicking what we are seeing in the retina. When you see incontinentia pigmenti at a later stage, you might only see a hyperpigmented rash. In the earlier stage, of course, it's a bullous rash, which you might diagnose, your dermatologist might diagnose, but you must definitely diagnose what's happening in the retina with the neovascularization and, of course, the fact that this baby can be lasered and does very well. Sometimes the other eye has already gone into a retinal fold and may require surgery. This was a syndrome credited to Michael Treacy's group. Actually fairly commonly seen. Anytime we see a coloboma, we must look to see if there's a persistent fetal vasculature syndrome, and a little more difficult to diagnose would be a lenticonus, especially a posterior lenticonus. But the importance of the MPPC syndrome is that it must alert us to send this baby to a neurologist because they have a lot of CNS malformations. Other conditions are literally written on the face. For example, this dermal hypoplasia with a rash initially and then hypertrophy will give us the fact that you must look for these subtle changes. You can see in the top left, the very early salt and pepper retinopathy, which might be mistaken for an infection. And then colobomas, how common are they? But do we always suspect other syndromes when we see colobomas? But when you see a coloboma, even if it's an aborted one, like in the top picture, if you see it with optic atrophy, which it shouldn't have, then one must think of Joubert syndrome and must get this baby investigated. We saw these hypopigmented patches. And who looks at the body when we are so busy looking at the eye? And that's where we have to change how we look at this baby, because the clue of what the diagnosis is was literally on the skin, and not this not so subtle hamartoma that you see along the inferior arcade. But in the fellow eye, you'd need a more keener eye to see this lesion here. Now the point is, these lesions can be multiple, and they might either light up on angiogram or not, depending on how the ILM is. So if the ILM is disrupted over that lesion, you will see it leaking or at least staining on angiography, and not if the ILM is intact. However, the OCT is a great marker. So here's an example of it not being shown on angiography, but seen on OCT, and we reported that the varying manifestations of these conditions. Trauma, well, fortunately, shaken baby syndrome, or what's nowadays called non-accidental infant trauma, is uncommon, I would say, in India, or perhaps underreported. So when we see traumatic lesions in the eye, one must think of a difficult delivery, or a post-conception injury, or a very difficult intubation if the child is required to be on mechanical ventilation. So Terson syndrome in an infant is not easily diagnosed because vitreous hemorrhage and retinal hemorrhages are so common. But OCT helps, and the fact that it is multiplanar, right from vitreous to retrohyaloid, and even retinal and subretinal as well. So if you see hemorrhages in more than one or two planes, it means you must suspect Terson syndrome. And those babies must be worked up quicker for a possible vitrectomy, otherwise amblyopia might set in. To summarize, get a very quick view of the posterior pole, because it's not easy to examine a baby who's crying and moving. Quickly take a systemic history. Ideally, examine the retinal periphery, because that's where a lot of clues are. Decide whether this is an acute condition, a chronic condition, or an acute and chronic condition. And do you need to follow up this patient yourself, or refer it not just to a colleague, but perhaps to a pediatrician, or as we saw, a pediatric neurologist, and that's where a multidisciplinary approach will be very appropriate. Thank you.
Thank you, Anand. Excellent description of all the neonatal and infant retinal findings. This is so between adult retina and a retina of an infant, what do you think are the differences, and how are the responses different if you talk about it generally?
Honestly, they are very different, because they say that baby is not a young adult. But drawing from what Chandran sir asked, I think that correlation between retinal vessels, cardiac, and heart is so evident in a baby. Especially, we learned this after the anti-VEGF era, when the VEGF was required for brain development, kidney and lung and heart development along with the eye. But the fact is that in a baby in the first few months, all the retina, if you discount the color, would be absolutely the same across ethnicities. So a Caucasian, and an African, an Asian, an Indian retina would be exactly the same. It's literally unblemished. So any abnormality, whether it's a spot, a patch, or a occluded vessel, or an abnormal segment, is abnormal, because otherwise it's it's unblemished and it looks literally the same. So I think in that respect, it's very different from an adult retina, which has so many variations, even in the normal. In the Downs case that we saw, we would almost overlook that supernumerary vessels, but it's almost a 85 to 90% occurrence in Downs babies. So, and sometimes, Downs may be a very easy diagnosis to make when you look at the child, but sometimes the other trisomies are not. And this supernumerary crowded vessels is a common feature among all trisomies, and it really helps us educate the pediatrician on where to take the investigation line.
Okay.
It's mainly in the nasal side, or?
Nasal side, the crowding is noted. Temporal side, supernumerary vessels are not noted. Narrowing of arcade is noted, and more. And the other thing is the discrepancy between the tessellations, which we so classically associate with myopia, with a very normal refractive error. So you have like a +1 or a +2, but you have tessellations, and you'd look at this fundus and you say, this must be -6, but no, it's +1. Again, a very common feature in these early retinal dystrophies or these trisomies.
Okay. Following up on Chandran sir's question, I just looked up the vascular histology. There's no significant difference in terms of histological differences between cardiac, neuro, and retinal vessels. They are all small, but retinal vessels obviously are much more smaller. All of them have 3 layers. The autoregulatory mechanisms are almost the same, but the response to the pathological stimuli are quite different. The cerebral and the cardiac vessels have more anastomosis, and not like, for example, a small block will not immediately damage the entire vessel like in a retinal vessel does. Sir.
What you see in the fundus is arterioles. They are not arteries.
Yeah.
Thank you. I invite Dr. Gopal Pillai for the last talk and panel discussion.
My talk has not been loaded here. I loaded yesterday. I loaded one folder.
It's not there.
Okay, so we'll have some more discussion on this. So, Dr. Rima, you had shown no PLI, which you treated, and so generally, many of these uveitis cases, do you think that the no perception of light can change into perception of light?
Yeah, if it's a vascular cause, I'm sure, and we have to make every effort to treat, because at times we feel no PL, nothing will be done, but we have to be investigating the patient more thoroughly, and even if there is no presence of any retinal manifestations or any optic nerve edema or pallor, it's worth giving a try. It's worth investigating with all the possible investigations, rheumatological as well as, I would say, always seek neurology and rheumatological opinion in such cases. And here it helped, and ultimately our diagnosis, when 6 months later the patient came up with this, ultimately our diagnosis turned out to be, it was basically a lupus retinopathy in the form of vascular occlusion, bilateral, sequential, in a case of neuropsychiatric SLA. And she was a case of psychiatric disorder. She had anxiety syndrome. She was, we couldn't really combine all of these things, and so it's worth, we need to investigate these patients.
The Eales disease, the old term, where are we placed now?
Dr. JB has shown beautifully that, Eales disease is a thing of the past when the etiology was tubercular. And, now it's Eales disease when it's idiopathic. And we are now terming it as tubercular retinal vasculitis when we have evidence of TB in any form, immunological or radiological. And now we don't use the term Eales disease. So can I take up, I have a question for you, Dr. Mahesh, for lifestyle diseases. Have you ever seen chronic CSC in families, in siblings?
Not really. Actually, I have seen pachychoroid PCVs. I have treated 3 sisters with polyps, 2 brothers with polyps and all, but not CSC. Probably they are all coming at a later age.
I don't know if
60s.
Among the audience anybody has seen, because
Pachychoroid disease I have.
I recently saw, yes sir?
One father and son.
Chronic CSC?
Yes.
Okay.
Both resolved spontaneously.
So,
And the other
okay.
was CSR. The sister had serous pigment epithelial detachments.
Why I'm asking is because I recently saw two real brothers, almost same age, identical chronic CSC, bilateral. So if you project their autofluorescence, it hardly differs. And both of them had a CNVM. So I really don't know whether the genetic...
Pachychoroid I have seen. I have polyps in the family.
Let's
So
go to some interesting cases, first of all.
Yeah.
So this is a 37-year-old female admitted with pyrexia of unknown origin. Counts were completely normal, but there was some lymphocytosis shift to left in the blood picture. Manto was negative, X-ray chest was normal, and blood cultures were negative. So, Rima, I would just want to ask you, how would you proceed in this case? This is a case where there's an exudative retinal detachment inferiorly, but almost something like a subretinal abscess here, and there was pyrexia of unknown origin as well. They are not able to, come to a diagnosis. They are asking the ophthalmologist what to do about this.
Do we have the HIV report?
HIV was negative actually.
And the CBC?
CBC was, counts were normal, but there was a shift to left. Lymphocytosis, predominant lymphocytosis.
Patient is stable neurologically?
Neurologically stable, fever is there, some cactication is there, emaciated look.
So,
and
here the X-ray chest is done. I would rather get a CT chest.
CT chest, yes.
Or maybe if there is slight, systemically, sometimes the patients don't look that comfortable. So I would go for a PET CT. I'm in a center where I can afford PET CT,
Okay.
but I would advise that for everybody.
All right. But this patient underwent a vitreous biopsy as well. Okay. And we got tuberculosis from this, and we treated her for tuberculosis. And the retinal condition also subsided with poor visual recovery. This was actually an abscess. So if this abscess were to be in the periphery, would you consider draining the abscess or something like that and see what is there? Will you get a positive culture?
No. So generally in tubercular abscesses, we don't really operate. We treat them with intravitreal anti-VEGF, along with anti-TB therapy, along with steroids. And biopsy, usually if the PCR is positive, which is unlikely. Did you get AFP from this?
No, we did PCR positive.
Just the PCR was positive. So if we have a tubercular subretinal abscess, the only way we intervene is in the form of anti-VEGF intravitreal, and we treat them with oral steroids and anti-TB therapy.
Okay. This next case is a dysthyroid ophthalmopathy. This patient had papilledema both eyes, and basically the patient had a decrease of vision as well. And you can see that all the muscles are constricting the optic nerve. And this is a patient in whom dysthyroid ophthalmopathy, there was proptosis also in this patient. So just to say myriad of causes of disc edema, one of the things is this thing as well. It's a very interesting case actually, carotid insufficiency. This patient had a vitreous hemorrhage. I operated him with a poor visual recovery. You can see that there is a seeming cherry red spot sort of appearance in that particular eye which had a vitreous hemorrhage.
Operated for what?
Vitreous hemorrhage.
Vitreous hemorrhage, okay.
Yeah. And when I did the other eye fluorescent angiography, you can see this large area of non-filling area around the any thoughts, Mahesh? The other eye. So this patient had carotid occlusion actually, both eyes. So maybe it was secondary to that. I think we have crossed the time. Let me thank all my co-instructors and the audience for having this wonderful instruction course. Thank you.
Thank you, Gopal.